for the first talk, which is on correcting common lower grades of astigmatism with enhanced monofocal IOLs. And for that, we have with us Dr. Tushar Agarwal. Dr. Tushar Agarwal is a professor of ophthalmology, serving in the cornea, cataract and refractive services department of the RP Center, All India Institute of Medical Sciences. He also holds the post of chairman, National Ophthalmic Surgical Skill Development Center. He is also the office in charge of the National Eye Bank. Over to Dr. Tushar Agarwal. Yeah.
Thank you very much, Dr. Anup. I'll be speaking about correction of low astigmatism with enhanced monofocal IOLs. I have no financial interest in the matter. Now, we encounter astigmatism quite commonly during cataract surgery. It's reported that almost half of our patients will have more than a diopter of astigmatism. And when we take the cutoff as about 1.5 diopters, then about 90% of our patients will fall under this category. Now, why is it important to address astigmatism at the time of surgery? Cataract surgery now being partly a refractive surgery along with the therapeutic surgery. If you leave 0.5 diopters of astigmatism on the table, the patient can still see 20 by 20. However, once we cross this sort of a red line above 0.5 diopters, you start to see a drop in the uncorrected visual acuity. And at 1.5 diopters, it drops to 612 or even worse. And this is the reason why we now address astigmatism at the time of cataract surgery itself. Now, there are various treatment modalities which have been described in the past, and which are some of them are current as well. You can do an axis phaco, which is placing your incision at the steeper axis. This can take care of around 0.5 diopters of astigmatism, but the predictability is low. Then you have things like arcuate keratotomy and LRIs, which have now again come into vogue with the femtolaser systems. They can correct higher degrees of astigmatism, but the predictability drops once you cross 1.5 diopters or more. Toric IOLs are the gold standard of management of astigmatism with cataract surgery. You have very reliable results and you can correct very high degrees of astigmatism. Others are staged corneal excimer laser procedures where the patient undergoes cataract surgeries and then later on the astigmatism is treated mostly with PRK. This is reserved for cases like IOL surprise or where the astigmatism actually sometimes increases after surgery. A big advantage of this procedure is that you can also take care of the surgically induced astigmatism. A couple of words about toric intraocular lenses. As I said, they have very reliable results. However, there are some limitations or some difficulties, like, for example, you do require additional preoperative workups. You might require extra instrumentation as well. And there are some cases in which the toric IOL implantation may not be feasible at all or may be very challenging. These include patients with very small pupils or corneal opacities. So this idea stems from some anecdotal experience which I had. We had to implant an enhanced monofocal lens and not a toric lens in patients with some pre-existing astigmatism. And we found to our surprise that they were seeing quite well even without correction. And then when we reviewed the literature and when we looked at the initial papers regarding the enhanced monofocal or even the EDOF lenses, we found that the authors also had sort of hypothesized that they may have higher astigmatic tolerance. And then we tried to sort of work it out backwards. How does an EDOF or an enhanced monofocal lens, I'm using the terms interchangeably, although technically they are not, but still in a broader sense they are. So a monofocal lens has a very single plane of focus, and a multifocal or a trifocal lenses, they have multiple planes. The EDOF lens or the enhanced monofocal lens works more by elongating the plane of focus itself. And if you correlate this with the concept of the astigmatism itself and Sturm's conoid, you'll find that the Sturm conoid is basically making the area of focus from a plane of focus to an elongated area. And this is exactly what the EDOF lenses counter. So with this hypothesis in mind, we conducted a study in which we recruited 38 patients. And we chose specifically the astigmatism range of 0.75 to 1.5 diopters for the reasons I've highlighted before. And one group underwent standard monofocal IOL implantation, and another underwent IHANS IOL, which is enhanced monofocal. Post-operatively, as you can see, the binocular UCVA didn't show any difference in the two groups at 3 months of follow-up. As expected, the intermediate vision was better in the patients with enhanced monofocal lenses. Now, this is how it works. So this is the defocus curve of both the patient groups. So what this primarily means is that how much of a lens difference, how much of an additional deviation from their refraction can the patients tolerate while still maintaining their UCVA. And you can find that almost EDOF lenses create a defocus sort of a margin of around 0.5 diopters. This is spherical equivalent. There was improvement seen in the uncorrected near visual acuity as well in these patients. The contrast sensitivity was also better. But here is where the results are interesting. If we take the cutoff as 6.9 or better, then only half of these patients who had 0.75 to 1.5 diopter astigmatism improved to 6.9 or better. Well, this is not acceptable. With toric lenses, this percentage goes up to almost 90%. But when we did a subgroup analysis where we subdivided the patients into two groups, one below 1 diopters, so essentially meaning that this group had 0.75 to 1 diopter of astigmatism, and the other group more than 1 diopter, then we find that the enhanced monofocal group had almost 85% patients 6.6 or better, and 86% patients 6.9 or better, compared to only half as seen in monofocal lenses. So this is where the advantage came forth of these lenses in this group. And as expected, as you can see, that when we talk about the uniocular uncorrected visual acuity, when we talk about 1 to 1.5 diopters, the percentage of patients having 6.6 or better dropped significantly. So to summarize, if we take the groups, a group of patients with astigmatism of 0.75 to 1.5 diopters, then you cannot expect a significant increase as a whole. However, if you take the patients who have 1 diopter or less of astigmatism, then you can expect almost 85% of the patients to see 6.6 or better. And this is where the advantage of this lens lies. To conclude, toric lenses remain the standard of care for managing any degrees of astigmatism preoperatively. However, enhanced monofocal lenses can also take care of patients who have 1 diopter or less of astigmatism. So essentially, we are talking about the group of patients who have 0.5 or more, but less than 1 diopter of astigmatism, where surgeons are in two minds whether to go for a toric IOL or not. This can be a good subgroup of patients where to try enhanced monofocal lenses. Thank you. Any questions? I'll be happy to take.
Thank you, sir. So this is this is a study which you have done in
yes.
Okay. So in these cases, when you used IHANDS, when you found the vision is good, did you place the section at the steep meridian?
No, so we didn't modify the incisions at all. All cases were done temporally. We didn't sort of take care into consideration the axis phaco or anything. So I would assume it's about 50-50 the distribution.
So probably then I think that's a very good thing, because it's a very simple way of managing.
This is a tricky subgroup, 0.5 diopters or more, the machine can say sometimes, if you're talking about things like IQ and all, so T2 lenses, the first lens which comes up. And some people, sometimes, you may not feel, okay, you can get away with it or something like that. So 0.5 to 1 diopters, I think, is a very good area to target. Of course, you get the additional benefit of having good intermediate visual as well, better near vision as well. And on top of it, you get, it's like a free add-on that you get, good UCVA in these patients. Especially, and even if you have both the choices, I think there are still a smaller subgroup where these lenses are not feasible, 100%. Like I said, when the pupil is very small, IFS type of cases, under topical anesthesia, it's not possible to retract the iris. So in those iffy type of cases also, I think it's a good choice if the astigmatism is up to 1 diopter, rather than a monofocal.
Thank you, Dr. Tushar. Yeah.
I call upon Dr. Anup to give away the memento to Dr. Tushar Agarwal.